Sepsis in neonates is associated with increased risk of morbidity and mortality. It is actually the number one cause of mortality in children under the age of 5 years in the pediatric population. Therefore, it makes prompt recognition and management very crucial in minimizing that mortality. The case that we'll be discussing around this week is a day 4 preterm neonate, very low birth weight at 30 weeks, who was found in the ward to have recurrent apneas, lethargy, hypothermia, and hypoglycemia. On examination, this neonate was found to be septic looking. He was jaundiced, dusky, mottled, and lethargic. He was also found to be poorly perfused with cold, clammy extremities with a capillary refill time of 4 seconds. He was tachycardic at 170 with mild hypotension. He was hypoglycemic with a moderate hypothermia. Sets were 95% on 21% BiPAP. He was also found to be mildly tachypneic with mild recessions. So these were the only positive findings that were found on this neonate, and this is the case that we'll be discussing around this week. Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. After having seen and examined the patient, an assessment of a preterm very low birth weight at 30 weeks with a late neonatal sepsis, most likely secondary to a hospital-acquired infection, and in septic shock was made. Now, looking at definitions of sepsis and septic shock in preterm neonates, there has been a lot of controversies and challenges in literature. This is mainly because of the immature organ system of these patients and the fact that they are still transitioning from the fetal to the neonatal circulation. So it makes it difficult to define things for them or to establish definitions for them. For example, a normal blood pressure for very low birth weight babies or for gestational age hasn't really been established. This is also mainly because we cannot use a blood pressure alone to identify an abnormal cardiac output, organ perfusion, or oxygen delivery in these patients. Now, because of these controversies that have been identified, there actually has been 3 different definitions that have been suggested and adapted to premature babies. And these definitions, they actually take 3 phases. Number 1, the presence of a SIRS, which is a systemic inflammatory response syndrome, 2, sepsis, and 3, septic shock. Now, in trying to identify this, like a SIRS, systemic inflammatory response syndrome, you actually need to have at least 2 of these. Examples are temperature instability, whether this neonate is having hyper or hypothermia. Number 2, they can have heart rate changes in the case of tachycardia or bradycardia. Number 3, they can have white cell count changes like leukocytosis or leukopenia. They can have CRP changes with a CRP of more than 10, or they can have more than 20% of immature to total neutrophil ratio. So these are some of the things that you can use to actually say this patient is having a SIRS. Now, sepsis is the presence of a SIRS together as a result of a suspected or proven infection. So you have a SIRS in a patient that clinically looks septic, or in a patient that has been proven to be septic by a positive culture. Then septic shock, it means you have sepsis which is defined by a SIRS as a result of a suspected or proven infection and together with cardiovascular dysfunction. So that's how you define septic shock. It is a sepsis together with a cardiovascular dysfunction, and sepsis, it is a SIRS as a result of a suspected or proven infection. And a SIRS is defined by temperature instabilities, heart rate changes, white cell count changes, CRP changes, and IT ratio changes. So I hope that makes sense. Now let's try to classify things. Like neonatal sepsis is actually categorized into 2. We have early onset sepsis and late onset sepsis. Early onset sepsis is any sepsis that occurs within the 3 days of life. And late onset sepsis is sepsis that occurs beyond 3 days of life. If you take a look at our patient, it's day 4 of life. So that's why, therefore, we will think this neonate is having a late onset sepsis because he is beyond 3 days of life. And being able to make this classification will also help you into suspect certain organisms in each category. For example, in an early onset sepsis, the main pathogens will be bacteria that colonize the maternal genital tract. These examples are GBS, E. coli, and things like Listeria. And of course, don't forget your torches, especially the syphilis, because that is what we commonly seeing in our unit. Then if you look at your late onset sepsis, you think of things like gram-positive, like staph, gram-negatives, that is E. coli, Enterobacteriaceae, your Pseudomonas. Don't forget your fungus, like Candida. And this will of course be guided by the pathogens that you are actually isolating in your unit. So for late onset sepsis, take into consideration the bacteria that are common in your unit, and therefore you will treat or think as such. Now let's look at the classification of shock. Shock can be classified as compensated, uncompensated, or irreversible. This classification looks at the underlying pathophysiology and therefore the clinical features that you will see in a patient because of that underlying pathophysiology. For example, in a compensated shock, we say it's compensated because there is a neuroendocrine compensatory mechanism through the hypothalamic pituitary adrenal axis, which will lead to the release of catecholamines and cortisol. And these catecholamines and cortisol will therefore lead to tachycardia, decreased urine output, poor perfusion, cold extremities, and a delayed capillary refill time. So when you're seeing such clinical features in a patient without hypotension, you can then safely say this patient is in a compensated shock. Whereas in an uncompensated shock, you have failure of that neuroendocrine compensatory mechanism to kick in, and therefore the patient will present with systemic hypotension and metabolic acidosis. In a case of irreversible shock, you have failure of the microcirculation. By that we mean, shock, when it causes tissue perfusion, there's usually microcirculation, like tissue capillaries that are supposed to kick in and try to perfuse that tissue. Now, when that microcirculation fails, that will lead to an irreparable cell damage, which will then lead to cell death, and we therefore call this an irreversible shock. This is the first way to classify septic shock. The second way you can classify shock is whether it is a warm shock or a cold shock. This again depends on the underlying pathophysiology and therefore the clinical features that will come. For example, in a case of warm shock, this is a patient who is vasodilated and therefore decreased systemic vascular resistance with an increased cardiac output. This clinically will make the patient to have warm extremities. They might have fever, they will have tachycardia, but they will have a normal capillary refill time because of the flushing of the tissues secondary to the vasodilation. Whereas in a case of cold shock, this is a patient who is peripherally vasoconstricted, therefore has increased systemic vascular resistance. How you would see this clinically is the patient with cold extremities, weak pulses, delayed capillary refill time, and oliguria. So this is the second classification of shock. Now let's take a look at the risk factors for neonatal sepsis. This can be classified into maternal, delivery room, and neonatal risk factors. Looking at maternal risk factors, you want to know if this is a booked or unbooked mom, as unbooked moms tend to have an increased risk of giving birth to babies with sepsis as their pregnancy was not monitored. Is this a mother who had fever during pregnancy or chorioamnionitis? Is this a mother who has GBS colonization? Those are some of the risk factors that you would want to know from the maternal side. Then delivery room. You want to know if you're dealing with a preterm or term baby. As preterm babies, they have an increased risk of sepsis because of the immature immune system, also because of the immature skin that is supposed to protect them from being colonized by bacteria? Are you dealing with a baby with birth asphyxia, a baby who has been resuscitated? Those are some of risk factors that you need to look at around delivery. Then neonatal risk factors. Is this a neonate with a vascular catheterization, especially in cases of central line, as those increase the risk of sepsis in the neonatal period? Is this a mechanically ventilated neonate, where you have introduced a foreign body like an ET cube and therefore increasing the risk of sepsis? Is it a baby who has been withheld with breastfeeding? As we know that breastfeeding, especially colostrum, they contain increased amount of immunoglobulins and white cell counts that are actually there to protect these kids from sepsis. Are you dealing with a neonate who is having a prolonged hospital stay, as those kind of neonates have an increased risk of hospital-acquired infection? So those are some of the risk factors for neonatal sepsis that you need to look at. Now let's take a look at the pathophysiology of neonatal sepsis. I know this is a busy picture, so I will try and simplify things. So it all starts with the bacterial invasion. So when the bacteria enters the body, it will activate your innate immune system, which is the first line of defense. These are neutrophils, macrophages, and monocytes. So what these cells will then do is that they will identify a certain pattern on each bacteria, and these patterns are called pathogen-associated molecular patterns, or PAMs. For example, if this is a gram-negative bacilli, those PAMs are called lipopolysaccharides on that certain bacteria. What these PAMs on the bacteria will then do is that they will attach on certain receptors on the immune cells, and these receptors are called pattern recognition receptors, because these receptors, they recognize those PAMs on those bacteria. So there will be a reaction between a certain bacteria because it has attached on a certain receptor on the immune cells. What then this will do is that it will trigger a release of inflammatory mediators such as interleukin-1s, your interleukin-6, tumor necrosis factors, etc. And then if nothing happens, if this inflammatory reaction doesn't get stopped here, it will then lead to a dysregulated inflammation. And a dysregulated inflammation will then lead to endothelial damage, which will then lead to a capillary leak. This is then what makes most of neonates that are septic to look edematous, because they have this capillary leak. And because of this endothelial damage, the coagulation pathway will be activated to try and seal the leaking capillaries, and then this patient will go into DIC. And if this infection or this inflammation still continues, it's not stopped here, the continuous capillary leak and continuous vasodilation of the capillaries will then eventually lead to hypotension and tissue hypoperfusion. And this will therefore lead to metabolic acidosis, because if there's tissue hypoperfusion, there will be anaerobic respiration with the release of lactate. And if this still continues, we don't intervene here, this hypoperfusion will then lead to end organ dysfunction. And eventually this patient will go into septic shock. So that is the pathophysiology of neonatal sepsis. I hope it makes sense. Sepsis in neonates can present non-specifically. This can range from things like lethargy, poor feeding, vomiting, feed intolerance, respiratory signs, temperature instabilities, apneas, turning blue. They can have heart rate changes. Now, if this is a neonate who is within the first 3 days of life, where they are still undergoing the normal physiological changes, this can actually make it difficult to diagnose sepsis, as their signs can actually overlap with the normal physiological transition. So this is something to keep in mind, so that you take it into consideration going forward. How do we then manage this neonatal sepsis and septic shock? So the first thing that you would want to make sure you do is to manage this neonate in an ICU setting. Number one, early recognition of symptoms. So the non-specific symptoms that we have discussed together with signs of shock. Do make sure you do a septic screen to look for SIRS, as we have discussed. Secondly, The first hour in managing a neonate with septic shock is called a golden hour. Therefore, airway, breathing, and circulation become important. Ensure the airway is patent. Provide oxygen to maintain sats at least above 94. Consider incubation and ventilation, especially if this is a neonate with recurrent apneas. Circulation, make sure to establish an IV access. Give a normal saline bolus of 10 ml per kg over 20 to 30 minutes. This can be given up to 20 ml per kg in preterm babies and 40 ml per kg in term babies. You can only repeat a fluid bolus if there was a response on the initial one. Vasopressors, in this golden hour, make sure to introduce your first line of vasopressors, which are things like dopamine and epinephrine, especially if this is a neonate with warm shock where the capillaries are vasodilated and there's a capillary leak. Your second line of vasopressors is things like norepinephrine, especially for cold shock. If you don't have norepinephrine, you can use things like dobutamine. Antibiotics, make sure you do use broad spectrum antibiotics. Look at your sensitivity resistant bacterial pathogen profile in your unit. For early onset sepsis in our unit, we use first line antibiotics like Ampi or Penji and Genta. Our second line is Piptas and Amic. Then third line antibiotics are things like vancomycin and meropenem. Not to forget antifungal cover, as this patient can also have candida infection. Control the source of infection. That is, remove any catheters that this patient is having, whether they are vascular catheters or urine catheters or any drains that this patient might be having as a source of infection. 3, you want to make sure you do continuous monitoring. Make sure the urine output is more than 1 ml per kg per hour. Monitor your vitals, your capillary refill time, and the mental status of this patient. And also make sure you monitor for complications like DIC and acute respiratory distress syndrome. Supportive care, make sure you remove any other thing that will increase the metabolic state in this neonate. So make sure your HGTs remain normal. Correct any electrolyte imbalances. Make sure you do add hydrocortisone in a patient who has shock that is refractory to catecholamines, or if you suspect adrenal insufficiency. The goals of management in a neonatal sepsis with septic shock are to restore perfusion, are to maintain oxygen delivery, and to control infection promptly. I hope this makes sense.